everyone, and welcome to the Parkinson's Foundation's PD Health at Home Wellness Wednesday. We're so glad you're here. Today's Wellness Wednesday webinar will focus on a surgical treatment option called deep brain stimulation that may help manage Parkinson's symptoms, and the recent advances in this technology hold promise for more effectiveness, personalized, and convenient treatment for Parkinson's symptoms. When standard medications are no longer managing movement symptoms, people with Parkinson's may explore other treatment options, such as deep brain stimulation, pump medications, and procedures like focused ultrasound. Our new guide, Advanced Treatment Options, is designed to answer common questions about these treatments and support informed conversations with your care team. You can learn how these treatments work, why they are used, and what to know before or after starting them. You can visit parkinson.org/library to read or download the free digital guide, or visit parkinson.org/store to order a free printed copy. Before we get into it, I want to remind you about our other PD Health at Home virtual programs. Each week, we offered sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, Ipi Salud en Casa. Be sure to visit our website to see what's coming up and explore our archived videos on YouTube. Our next Wellness Wednesday will address some of the hardest parts of living with Parkinson's: cognitive changes and dementia. We'll explore ways to support safety and quality of life through medical, emotional, and social support, and we'll offer practical tips to better understand and manage dementia-related changes. You can learn more about upcoming virtual programs and register at parkinson.org/PDHealth. The Parkinson's Foundation wants to thank Boston Scientific for sponsoring today's webinar. We thank Boston Scientific for supporting the mission of the Parkinson's Foundation. And now I would like to introduce our guest expert for today's Wellness Wednesday, Dr. Arjun Tarakad. Dr. Tarakad is an associate professor of neurology at Baylor College of Medicine, where he also serves as the director of the Deep Brain Stimulation program within the Parkinson's Disease and Movement Disorders Clinic. Baylor is a Parkinson's Foundation Center of Excellence, and Dr. Tarakad brings deep clinical expertise and thoughtful insight to the care of people living with Parkinson's. We're grateful to have him with us today. Welcome, Dr. Tarakad.
Thank you, Krista. Just wanted to thank the Parkinson's Foundation for letting me do this talk. I do have a lot of interest in Parkinson's and deep brain stimulation specifically, and today we're going to be talking about some innovations within the deep brain stimulation space for Parkinson's disease. So a lot has changed in the field just in the last few years. So we're going to try to go through a little bit of that and how that can impact you on the patient side, as well as how it might change things for your clinicians. So the slide, okay, good. The slides pulled up here, so we can go to the next slide. So these are just the objectives for today's talk. Coming in, I do think the hope is that you all have at least some familiarity with DBS, but we are gonna go through the basics of DBS to understand what exactly it does in Parkinson's disease, when it should be used, the surgical targets that we have for DBS and Parkinson's, and then the components of the DBS system. The bulk of the talk is going to be on exploring recent advances in DBS technology. This is both hardware advancements, programming tools, and briefly surgical techniques. I'm not a neurosurgeon, so I kind of will steer clear of too much of that. And then also talk about how these changes directly impact you as a person living with Parkinson's disease, how these advancements can be applicable to your care. And then we're also going to briefly talk about how this new technology can be applied even to people who have already had DBS surgery. So a lot of these changes are not just for people who are looking at surgery, but people who have already had it done. You can go to the next slide. Okay, so what is deep brain stimulation surgery? So DBS is an advanced surgical procedure for people with Parkinson's, where a wire is implanted into deep structures within the brain, where they apply an electrical current or stimulation. So electrical stimulation effectively inactivates the targeted structure in the brain, meaning that the primary effect of deep brain stimulation is through inhibition. This is a very surface level understanding of DBS. In truth, there's a lot more complexity on where the nerve cells or connecting fibers sit within an electrical field that can lead to both excitatory and inhibitory effects on cells. Another way that I think it's helpful to think about how DBS works is to disrupt pathologic neural networks that can develop in disease states like Parkinson's disease. So there's a lot of talk when you think about AI and other things about neural networks. We know with conditions like Parkinson's, there might be patterns or groups of cells that function abnormally, and DBS works to kind of disrupt those abnormal patterns to try to restore normal function. You can go to the next slide. So who is DBS for? We think of DBS and Parkinson's disease in a few typical cases, though there are also a few special case uses. The most common reason to pursue DBS includes when someone has motor fluctuations and dyskinesias. So both of these are complications that typically occur in long-standing disease as a consequence of long-term use of levodopa. So motor fluctuations are transitions between on states when medications feel like they're working and off states when symptoms feel like they're coming back. When people have had Parkinson's disease longer, they might feel like medications don't work as well or they don't last as long. They might need higher or more frequent dosing, and this is what we would say is a worsening of motor fluctuations. On the other hand, dyskinesias are involuntary movements that are associated with medication use. Most typically, these are what we call peak dose dyskinesias occurring when medication doses are high, but they can also occur in transition states between meds when meds are kicking in or when they're wearing off. When someone has both motor fluctuations and dyskinesias, the pharmacologic treatments that we have are somewhat limited. So this is one time when we often start discussing the possibility of deep brain stimulation. Another common reason to pursue deep brain stimulation is for refractory tremor. So this is tremor that doesn't respond sufficiently to medication. It's worth noting that only about 50% of people with tremor in Parkinson's disease are going to see a benefit to their tremor with levodopa. So if you're in that 50% where your tremor doesn't really respond to levodopa or other tremor medications, it's a common reason that we might be looking at pursuing deep brain stimulation fairly early on in the Parkinson's disease course. A less common reason that we may pursue surgery typically revolves around medication tolerance. So these would be things like extreme nausea or low blood pressure with the medication that just limits its use. Just as important as why we might look for who's a good candidate for DBS, we also want to know when surgery isn't going to be a good option. So when we talk about limitations of deep brain stimulation, it's generally ineffective in addressing non-motor symptoms. So these would be things like cognitive changes or fatigue. I have a little asterisk there because if you have side effects caused by medication, like sleepiness caused by medication, that might get better if you cut down on your meds with surgery, but the surgery itself is usually not going to be very good at addressing these non-motor symptoms. It's also ineffective at treating most motor symptoms that don't respond to medication. So if you have balance problems that don't seem to get better with the pills, it's unreliable to say that that symptom would get better with something like deep brain stimulation surgery. The one exception there, as I mentioned earlier, would be tremor. So even tremor that doesn't respond to medication typically responds very well to surgery. Another reason that we might move away from deep brain stimulation surgery is if you have an elevated surgical risk. And in most cases, this ties in with cognition. So if someone has dementia or more significant cognitive issues, the risk of doing any neurosurgical procedure increases the risk of progression of those cognitive issues. So typically, beyond a certain threshold, we would say that cognitive problems might exclude you or at least severely limit the possibility of pursuing DBS. We can move to the next slide. So now we're going to talk about different targets for DBS. So there are 3 FDA-approved targets for DBS and Parkinson's disease, and an overwhelming majority of cases are going to be directed at these locations. The first two locations, the GPI or globus pallidus interna and STN subthalamic nucleus, have been extensively studied and compared and are generally felt to be comparable to each other. So in the past, there were a lot of discussions about what's the better target, and now we know that they are roughly equivalent. Some centers might exclusively just implant in one of these targets with good success. However, there are some minor differences between the targets and what might guide target selection. So in general, we would say that the globus pallidus interna might be a little bit better at treating dystonia symptoms of Parkinson's. So these are things like involuntary muscle contractions. And it's also good at directly suppressing dyskinesias. So when you turn up stimulation, you can directly reduce the dyskinesias. One thing worth noting is with GPI stimulation, you typically don't change your medication doses, or at least not significantly. So even if you're less reliant on medication, you typically remain on roughly the same dose you were taking before the surgery. In contrast, the subthalamic nucleus is probably a little bit better for tremor control and a little bit better at addressing bradykinesia or slowness. You typically see greater medication reduction with STN target, but it's worth noting that this reduction is often necessary, not just optional. So the way that you reduce dyskinesias with STN stimulation is by taking less medication. So if you had symptoms that you needed to keep taking the medication for, you might run into more trouble with dyskinesias with STN. The third target here is the VIM, or ventral intermediate nucleus of the thalamus. This target is also used for a condition called essential tremor, and it's probably our most effective target for treating tremor, but it has fairly minimal effect on treating other symptoms in Parkinson's. You can go to the next slide. So now we're going to talk about components of the DBS system. So there are three main components. The DBS lead, which is a thin wire, which has 8 to 16 contacts on one end. Older devices used to have 4 contacts. There's the extension wire, which is just a wire that connects the DBS lead to the IPG. And then there's IPG, or implantable pulse generator. So this is really the brains of the device as well as the battery. This is what sends the stimulation programs to the lead. It stores all the programs and the controls that patients or clinicians might apply to the stimulator. It also has the ability to record data, such as device usage. On a rechargeable battery, it can record charging history, and then brain recordings on certain devices. You can go to the next slide. To give the context of recent advances in DBS, I think it's worthwhile taking a look back at the history of DBS. This is a very, very brief summary. So DBS has been around for quite a long time. So in the 1960s, it was used as an adjunct to radiosurgery, which was a precursor to DBS, where they made physical lesions in brain targets to treat neurologic conditions, including Parkinson's disease. It wasn't until the 1970s or 1980s where they started implanting DBS devices. This was piggybacking off of technology that was used in cardiac pacemakers, but it was still more of an investigational and research type of treatment. It was used at a few academic institutions, but not really widely used. DBS targeting for the VIM nucleus first got FDA approval to treat essential tremor and Parkinson's disease in 1997. And then STN and GPI targets were approved for Parkinson's disease in 2002. You can go to the next slide. So when we look at hardware development following approval of DBS, a few things can stand out. So for the first 20 or so years that DBS was available in the US, there was just a sole manufacturer, Medtronic. And while technology continued to advance during that time, it did so at a slightly slower pace. Over this period of time, the DBS leads, the wires that go in the brain, stayed fairly consistent with 4 what we call omnidirectional contact points for stimulation. In 2016, Abbott, which at the time was St. Jude, released their first commercial DBS device in the US, and then Boston Scientific followed a year later. Around this time is when you start to see a lot more competition, and that bred a lot more innovation. You can see this timeline is much more weighted towards the 2016 onwards. So in 2016, Abbott was the first to release a directional lead along with their system. Boston Scientific followed suit in 2019, and then Medtronic in 2021. Boston Scientific released updated directional leads going from 8 contacts to 16 contacts in 2025. And then beyond battery updates, all the manufacturers have continued to release software updates, the major ones I've listed on that timeline. So Abbott released their Neurosphere, which is a virtual clinic, and Medtronic enabled their brain sense recordings in 2021. Abbott, or sorry, Boston Scientific released their image-guided programming in 2022, and then AI-guided programming in 2024. And in 2025, Medtronic released their adaptive DBS feature. So you can see, especially in the last 5 to 7 years, there's been a lot of change and innovation in the DBS space. We can go to the next slide. So one of the first areas that we'll dive into a little bit deeper is with the DBS battery. So over the years, the technology have allowed for the footprints of batteries to get smaller and also get a little bit thinner. On top of that, they can sit a little bit more comfortably where they're implanted. So this is taking feedback both from patients and experience. The batteries have gotten a lot rounder to help minimize the discomfort. In the pictures at the bottom, you can see side-by-side comparisons from all the manufacturers. Just one disclosure on this, I did use ChatGPT to clean up the images and get rid of the background and the shadows. So I included thumbnails on the left of the original pictures because it did somehow morph the devices slightly. But you get a general idea. They're all comparable in size. The top 3 batteries are the rechargeable, which are obviously smaller. The bottom 4 batteries are the non-rechargeable batteries. We can go to the next slide. So beyond the size and shape of the IPGs, there have been a lot of advances in the technology of the battery itself. So the first rechargeable came out in 2009, and a lot of the advances since then are obviously thanks to developments in other tech like smartphones, though the batteries in DBS are still very different than the batteries in smartphones, both in how they function and in their form. Some tangible benefits both to rechargeable and non-rechargeable batteries are increasing capacity, and this is despite reducing the size. So the non-rechargeable batteries have around a 30% larger capacity compared to prior generations, despite the smaller footprint. And with rechargeable batteries, the larger capacity has reduced the need to charge the devices as frequently. So most patients get away with charging once a week or less versus multiple times a week with the older devices. The charging experience has also drastically improved over the years. So in the past, people often need to go through multiple charging sessions if their battery was very discharged. Now they can complete full charging typically in a 45-minute session. Even for an almost depleted battery, you can charge it to full within about an hour. And then some of the newer batteries you can charge just on a daily basis for very short periods of time, like 10 minutes, if you wanted to do frequent but short charging. For anyone who used the first generation rechargeable battery, they'd also know that it was a lot more finicky with how you would charge. So the charger had to sit just right, the orientation had to be just right, or you would get these disconnections, and the new batteries are much better with the wireless charging. The larger capacity has also led to improvements in longevity. So these batteries can go through more cycles than older batteries, and rather than the system reaching an end of service and just shutting off, the newer technology works indefinitely, albeit at a reduced capacity. So you don't have to worry about the stimulator shutting itself off before you get the battery replaced. We can go to the next slide. So next we're going to talk about the DBS lead technology. So as I mentioned earlier, for the first 20 years, DBS was commercially available in the US. Leads were limited to just 4 contacts. There was some variation with the lead spacing to better conform to different targets in the brain. If you look at the top right picture, the very top right 2 leads, you can see there the wider and the narrower, those are the old leads from 20 years ago. Outside of that, there really wasn't much innovation in the space. And then after Abbott released their first directional lead, Boston quickly followed and Medtronic followed suit. And up until recently, it's been pretty standard across all manufacturers that they use these 8 contact leads, so from 4 to 8 contacts following a 1-3-3-1 configuration. So what this means is the top lead and the bottom lead are omnidirectional, so a single lead, and then the 2 middle leads are directional, meaning they're sub-segments of the lead that point out in 3 different directions. And what this really translates to is going from one axis of control. So when we would stimulate along the lead, we could control the depth of stimulation to now having 3 axes of control, because at any given depth, we can choose direction in that plane to stimulate or to shift stimulation more in a particular direction. And this exponentially increases the combinations of stimulation patterns that can be applied in a given person. Which means it also greatly increases the complexity of DBS. And then last year, Boston went one step further and released their 16 contact leads. So those 2 are pictured in the larger figure here on the left-hand side with a 1-3-3-3-3-3 configuration and a 1-1-1 1-3-3-3-3 configuration. So again, expanding the possibilities of stimulation along with increasing the complexity. You can go to the next slide. So why this matters is when we talk about directional stimulation, I'll go through with the next few slides here. So to orient you to the image on the screen, the picture on the left shows the DBS lead as it sits relative to the subthalamic nucleus. So the subthalamic nucleus is the area highlighted in green. The predicted field of stimulation based on the settings is the red sphere. And then on the right-hand side of the picture, you can see the current DBS settings. So in this case, we're simulating contact. We're stimulating contact on all 3 of the sub-contacts that you can see in the picture. This is to simulate an omnidirectional stimulation of an older 4-contact DBS lead. In this particular case, you can see that the DBS lead is sitting a little bit to one side of the STN, so it's not perfectly in the middle of the STN. So when you stimulate the target, so that red area, some of it is going into the green, which is the target area, but a large portion of that stimulation is also outside of the green bubble. We can go to the next slide. So in the second picture, you can see what happens if we continue with that omnidirectional stimulation, so stimulating all 3 areas, but we apply something called differential stimulation, which we'll talk about a little bit later. So this is akin to what you would see if you had one of the newer, more capable batteries, but you were still on one of the old 4-lead omnidirectional systems. In this case, you can see that we were able to shift the stimulation down along that single axis to better sit within the green area of the STN. However, a significant portion of that cone still sits outside of the STN. We can go to the next slide. So in the third picture, we can see that we're utilizing directional DBS. So in this case where the stimulation is sitting a little bit further in the green target with fairly minimal spill outside of the target. It's also worth noting that while the area in that STN being stimulated is greater than in the first, or second examples, sorry about that. The amount of energy being delivered or the current is actually a little lower. So if you look at the stimulation settings on the right, this is down to 1.3 milliamps compared to 1.5 on the earlier slides. We can go to the next slide. So aside from the location of stimulation, there have been a number of developments in the parameters that we can simulate, or how we can simulate different parameters. So all IPGs from the 3 main manufacturers still have 3 main parameters that can be adjusted on how to deliver stimulation. Okay, so basically all the different systems have these 3 parameters, and the newer systems have new ways that we can adjust these parameters. So when we look at newer systems, the big changes are the current is now what we call constant current, so that amplitude switched from voltage to current. The pulse width has a little bit of increased range, so we can go lower on the pulse width than in the past. And then with the frequency, we can use multiple independent frequencies. There's also a new feature called anodic stimulation, which I'll talk about. So I'll go through all these in more detail on the next slide. So constant current, like I mentioned, is the new change in all the systems, and this is because it applies a more stable stimulation compared to constant voltage systems. So up through the Activa system, which was developed in 2009, all the systems use constant voltage. But anyone upgrading to new systems, even with the old wires now, they might notice that their stimulation just works a little better, even if their settings stay the same, because it's applying the stimulation in a little bit more stable manner. So the second parameter that we talked about, the pulse width. So on older systems, there was a lower limit on the pulse width of 60 microseconds. But one thing that we saw just with experience with programming is that pulse width is very closely tied to certain side effects. So there's a structure in the brain adjacent to all the targets that we use in DBS called the internal capsule. And we know that stimulation at higher pulse widths tends to preferentially stimulate the internal capsule, which can lead to side effects like speech changes or muscle pulling. So switching to the new batteries, we found that with a lot of patients, when we drop that pulse width a little bit lower, it can alleviate some of those side effects that we can see, like muscle pulling or speech changes. The lower pulse width has also been shown to better control some symptoms like proximal tremor or something called ataxia or incoordination that you might see in Parkinson's or other neurologic conditions. We can go to the next slide. So moving on to the frequency. So due to technical limitations, the older systems required that the frequency be kept constant across all leads that were connected to a given IPG. And as we know, PD symptoms, brain anatomy, and even lead placement usually demonstrate some degree of asymmetry. So with newer systems, we can independently control the frequency on each side, which allows a little bit more freedom in choosing optimal settings on each side of the body. The last feature that I'm mentioning here is anodic stimulation. So this is effectively reversing the polarity of stimulation. Some studies have suggested that anodic stimulation may help mitigate some of the stimulation-induced side effects that we can see in some patients. So while it typically requires fairly high settings, meaning a higher battery drain, it can be effective in select cases to reduce DBS-induced side effects. You can go to the next slide. So next we have differential stimulation. So this is another feature that I briefly touched on earlier. This is also known as multiple independent current control, or MICC. So with older systems, it was possible to stimulate multiple contacts, but you had to give the same amount of stimulation to each contact that you were stimulating. In the newer systems, you can actually control exactly what portion of the stimulation goes to each contact. And the obvious way that this can be of greater benefit is, again, more flexibility in programming. So when you look at a GBS lead using MICC, we can stimulate any area along the lead rather than discrete points where there are contacts. So you can kind of stimulate in between two contacts by giving differential amounts to each of the contacts. You can go to the next slide. There's also, though, this less intuitive aspect there's also this less intuitive aspect to MICC that we're using a little bit more recently, which is the ability to stimulate multiple targets. So in the example in the picture, you can see that we're actually stimulating a sizable portion of the STN, that green territory, but you can also see this little red bubble in the area above that green territory. So this is an area called the zona incerta, which sits slightly above the STN. This is a region of the brain that can be used to directly suppress dyskinesias. So if you remember earlier when we were talking about STN stimulation needing to treat dyskinesias by reducing medication, now we have an ability to directly suppress the dyskinesias by just targeting an area in the brain near the STN, in addition to stimulating the STN. If we were to move up even higher on that lead, we can actually start to get into fibers that reach the VIM, that tremor area in Parkinson's. So again, we might be able to target multiple brain structures with a single lead when we use this independent current control to stimulate different locations. We can go to the next slide. Sorry. So the next thing that we're going to talk about is adaptive DBS, and this is something that's got quite a bit of attention over the last year. ADBS, or adaptive DBS, works by recording brain signals. These are known as local field potentials, and then modulating stimulation accordingly. This is useful because certain LFP signals are known to correlate with specific symptoms of Parkinson's. For example, beta frequencies, which are sometimes referred to as the beta band, are well described in Parkinson's patients and known to increase during off periods, such as when people don't take their medication, and they're also suppressed during on periods, like when people take their medication or DBS stimulation is applied. We can go to the next slide. So this means that the system now has a way to confirm the treatment that it's applying is having a desired effect. And this is what we refer to as closed loop stimulation, because it's that feedback to the stimulation pathway. In this image, you can see the recordings or signal intensity at the identified beta peak, that 23 or 21 hertz, and then how this fluctuates over time in that top graph. The bottom graph shows the oscillation between high and low stimulation on the device that's responding to those elevations in the beta peak beyond a certain threshold with an increased level of stimulation. We can go to the next slide. The other area where I think LFP can aid with treatment is by allowing clinicians to indirectly track symptoms over extended periods of time. So when we look at beta activity, we can look to see if there's certain times of the day that a patient looks a little bit more undertreated, or if on the whole they look a little bit over or undertreated. That can guide adjustments in both stimulation and medication dosing. While there's a lot of potential with DBS, I do want to stress there are many limitations. So you should be careful to interpret the potential with ADBS. So first off, not all symptoms correlate with LFP signals. One great example is tremor. So tremor doesn't consistently correlate with any particular LFP signal, and even dyskinesias can show some variability in how they show up on LFPs. Second, not all patients will have usable LFP signals. So while there might be some workarounds, there are going to be a subset of people with adaptive DBS where the feature really isn't usable. Third, so utilizing adaptive DBS requires specific electrode configurations. So many of our earlier discussions about things like directional stimulation and MICC are significantly restricted when you're using ADBS. So in some cases, it might require choosing between the optimal stimulation location or the ADBS feature. And then lastly, ADBS does use more batteries. So recording just naturally is going to require a little bit more of a battery drain. That could be counteracted by the lower levels of stimulation you need as a whole, but it is something to consider when you're using this feature. We can go to the next slide. So the last of the software features that I'm going to talk about is image-guided programming. So this has already been visible on several of the prior slides, but I think it's worth discussing this explicitly. So the ability to neatly visualize the DBS lead sitting and where it sits relative to structures in the brain is actually a fairly recent development. And more recent still is this ability to directly incorporate the data into the programmer and being able to see in real time how changes to the stimulation program affect the location of stimulation within the brain. We can go to the next slide. So the largest benefit of this is for us to quickly optimize the location of stimulation. In the past, without the imaging support, we had to blindly test all the contacts, document for side effects and benefits, and try to develop this mental map of where the lead was sitting in space. And this required both an extensive understanding of neuroanatomy, and also there would always be the questions of reliability, because not everyone is going to experience or describe symptoms or side effects the same way. So there was a lot more trial and error, I would say, in the past with deep brain stimulation. We can go to the next slide. So the rest of the advances we're going to talk about are maybe a little bit more easy to understand or appreciate the changes. So when we look at changes in the patient experience, so one of the big ones is the patient controllers. So a lot of the devices now use smartphone or smartphone interfaces. So the positives of this is everything is just spelled out on the app. It's very easy to update and change when it needs to be changed. One downside I've heard is usability, especially for people with tremor or fine motor control. Some people just prefer those physical buttons to the touch screen. The other major advancement in the patient experience is with remote programming. So with some of the devices, the clinician can actually connect virtually to the patient through their controller and remotely adjust stimulation settings. I think this is particularly useful for long distance patients. There's still rules across state lines for medical licenses, but if you're within the state or your physician has a license in the state that you live, these virtual visits are certainly an option. Also useful for people who might have mobility or transportation difficulties. And then it can facilitate altered strategies when we look at programming. So people might do very frequent follow-up programming visits if they're able to do them virtually. So you might be able to do frequent short visits rather than those longer initial programming visits. Now we can go to the next slide. So briefly talking about changes in the surgical procedure. So there's been a lot of improvements and advancements in imaging software, as well as this thing called frameless surgery. So in the past, they had to use this bulky frame attached to your head to make sure that everything was getting into the right spot. And now they're able to do it with a lot less hardware. And why this is relevant is it means that their surgical time is shorter, which means less time under anesthesia, more accurate placement of the wire, which means easier job for us when we're programming, better response for you after you get the surgery. And I think the biggest one that our patients appreciate is the sleep surgery. So in the past, all DBS surgeries had to be done awake because we had to do testing and recording to kind of confirm that we were in the target location that we wanted in the brain. Now, because these imaging systems and hardware have gotten so accurate, some centers, including ours, are able to do a bulk of our surgeries asleep. And I think that's been one of the biggest barriers that we've been able to overcome for patients who were very nervous at the prospect of being awake during the surgery. We can go to the next slide. The next topic here is advances in the clinician experience. So as I have mentioned, as you can see, the complexity of DBS has increased quite a bit over the past 5 to 7 years. Not all neurologists are movement disorder specialists, and not all movement disorder specialists routinely do DBS. However, depending on where you live, you might have a general neurologist, a neurosurgeon, or a movement specialist managing your deep brain stimulator. So even with experienced programmers, there's so many different parameters that the process has become a lot more time consuming. We can go to the next slide. So the manufacturers have heard this and I think appreciate this. So they've developed a number of tools that make it a little bit easier and more accessible to do this kind of complicated programming. So the two big ones that I'm going to touch on here, one is this thing called the electrode identifier. So this ties in with the local field potentials or that adaptive DBS that I talked about earlier. It's basically using a computer software to automatically record and then select the location of stimulation that it felt had the best LFP signal. And then the second, this Illumina 3D, is using the image guided software. So it uses AI to automatically generate a stimulation field that best fills the target nuclei or avoids adjacent structures. So you can kind of control how much you want to fill your target or avoid adjacent structures, and it'll come up with a combination of electrodes that can do that best. We can go to the next slide. So who can make use of the new DBS technology? The new leads do require a new DBS surgery, which means another brain surgery, and that's not typically done on someone who already has DBS surgery with a good response. If you don't have a good response, it's certainly something that might be discussed with the neurosurgeon, but once the leads go in, it takes a lot for us to want to take them out and change them. So it's not a typical case scenario. When we look at the IPGs or the brains, the hardware that we talk about, those are often backwards compatible with the leads. So we do have people who were implanted 20 plus years ago, so their leads are 20 or more years old. But they can still make use of things like adaptive DBS by implanting the new IPG connected to their old leads. DBS IPGs are also often cross-compatible, so an individual with a Medtronic lead from 20 years ago could change to a Boston battery to make use of some of the image-guided programming and the anodic stimulation features. Though it's worth noting that when you do mix manufacturers like this, sometimes you can lose some of the functionality as well as sometimes lose the MRI compatibility, though not always. And then manufacturers are constantly pushing updates to the software. So features like image-guided programming and adaptive DBS, which are more recent when they came out, the hardware that they work on was a number of years older. So these things just kind of popped up as a software update and a new feature that we could use on patients as they push those updates. We can go to the next slide. So just briefly talking about future directions for DBS technology, so where we're headed down the line. So batteries are continuing to get smaller and better. One of the discussions has been around just a scalp implanted battery. So this would be the idea of something the size of maybe a coin, where you wear a helmet overnight and you can just charge it overnight each night and there's no implanted device in the chest. Also utilizing AI symptom tracking. So this can be both through things like wearables, but also with even video visits. You can monitor things like tremor or facial expression to help guide stimulation responses and try to identify those optimal stimulation settings. And then the use of new brain signal recording. So we did talk about LFPs. There are ranges of LFPs that the current systems aren't really able to track, including ones for things like dyskinesias. And then there are other brain signals separate from LFPs, things like this evoked resonant neural activity or ERNAs that provide new targets for closed loop stimulation in the future. So with that, I think we're done. You can go to the last slide here. I just wanted to thank Parkinson's Foundation, Boston Scientific for sponsoring this talk. As well as my DBS team, who you can see in the picture on the left. I apologize for the technical difficulties with this, but I'm free to take questions now if you have any.
Thank you so much, Dr. Tarakad. I've learned so much about I want to say, progression, the evolution of the devices and the technology of deep brain stimulation. So thank you so much for offering this presentation today, and want to give a big shout out to today's sponsor, Boston Scientific, for supporting the work of the Parkinson's Foundation and being a part of this movement forward in technology. So thank you, Boston Scientific, for your support. Want to get into some questions for us today, Dr. Tarakad. I'm curious, when we think about deep brain stimulation, is there a point in time in our disease progression where it might be too soon to consider this type of surgery?
So I always try to avoid generalizations with it because each person is kind of very specific with their treatment. There
Yeah.
has also been discussion more recently about doing DBS earlier in Parkinson's to try to avoid some of those complications of things like medications. That being said, it is a brain surgery, and brain surgery does carry its own risks. So that threshold for risk might be different from person to person, but in general, we would say that you need an adequate trial of medication, because if you can get to a level of functioning that you're happy with just with pills, there's not really, I'd say, a strong motivation to want to do a brain surgery and all the risks that go along with that. That being said, we do have situations, let's say someone is working, they can't carry pills with them when they're at work, and even maybe minor symptoms are more impairing. So they have just a little bit of tremor, but they're a trial attorney, let's say, and they don't want to have that little bit of tremor in their hand. They might opt to do the surgery a little bit earlier because that little degree of tremor control is very important to them. I would say the important thing is you should have had an adequate trial of medication. But beyond that, I wouldn't say there's a point that's too early, provided you've had that trial. There's also the concept of something called the DBS window, so a time when it might be too late. And I think this is a discussion I get into more often with patients where people will say, well, I do want to get DBS sometime, but only when things get really bad. I don't want to really do it now. And I think the thing is, no one wants, or not no one, but few people are going to want to have someone put a wire in their brain. Like doing brain surgery is a scary thing. So I don't think people are usually keen on doing that, but they do want the benefits from it. So what I usually tell people is if you're getting limited in what you're able to do or what you want to be able to do, and those symptoms are things that we know could improve with DBS, that would be a time to consider it.
Thanks for outlining that. And I know there's so many other considerations to think about in conversations with the providers and multiple consultations that go into before getting the actual surgery to see if you are a good candidate. And that is another presentation that we can have, Dr. Tarakad. And I want to talk a little bit. We've got quite a few questions about adaptive DBS. One particularly about being specific type of probe. So the question we received from one of our viewers today, adaptive DBS is limited to a specific type of probe. Is that correct or incorrect? And can you explain that a little bit more?
Uh, to a certain degree, correct. So right now, adaptive DBS is limited to Medtronic systems. And with Medtronic, they aren't cross-compatible with other manufacturers. So other manufacturers can connect to Medtronic leads, but Medtronic devices don't connect to other manufacturer leads. So you are limited to Medtronic leads or probes, if you want to call them that, to do adaptive DBS. But even the older Medtronic leads, so the ones from 10 years ago, 15 years ago, are capable of doing the recording and the stimulation for adaptive DBS. That being said, their newer hardware is better optimized for it. So the recordings you get are going to probably be a little bit cleaner, and your capabilities for stimulation are going to be a little bit broader with newer wires that are adapted for that adaptive DBS than those older wires, but it is still compatible with your older wires.
Okay. We're getting a lot of questions about what DBS treats. What are the symptoms that it actually helps? So, I'm going to share some of the things that our viewers are asking about. Does DBS help rigidity? Does it help tremors? Does it address dystonia, severe hallucinations, gait freezing, balance challenges? So, I spitballed that to you, Dr. Tarakad, so you could have an idea of what our viewers are asking about. And I would love to hear your impressions after hearing that. What does DBS help with?
So I would say the potential for DBS is to help with all motor symptoms of Parkinson's that respond to levodopa. And I want to be clear, this is potential, so it doesn't guarantee it. There's some things that might more reliably respond or less reliably respond, but anything that gets better when you take the levodopa from a movement standpoint could get better with deep brain stimulation. You might ask if it gets better with levodopa, why am I doing DBS? The idea is you have a more consistent response, so you're not having those ups and downs, those fluctuations. You're not running into side effects that you get with the medication. So it's a more sustained response or like better function. We say you're best on time. So whatever you're doing when you're functioning at your best, you get a longer stretch of that time when you get deep brain stimulation.
Could you
So
say a statement for us one more time? DBS works when you're not having a response to carbidopa levodopa.
DBS works at your best on time. So when you're functioning at your best with carbidopa levodopa, so let's say you take the medication 4 times a day, you do really well for 2 hours in the morning, and the rest of the day you're kind of off and on and not that great. Those 2 hours in the morning, you could stretch that out to maybe like 10 hours if you have a good response with DBS. So it prolongs that on like good on time with DBS. That's really where you see the most benefit. Breaking it down a little bit more when we look at specific symptoms, DBS is very reliable in treating tremor. So it is our best treatment kind of without question for tremor. So whether or not your tremor gets better with medication, it almost guaranteed is going to improve with deep brain stimulation. Uh, for symptoms like rigidity and slowness, it's also very effective. So we would say reliably, you get a response comparable to what you would get with medication, just for longer with the stimulation. When you look at something like rigidity, you're having these fluctuations overnight. So you have these long stretches where you might not be taking medication, so those symptoms can build up a little bit more. So when you consider 24/7 stimulation, a lot of patients will notice things like rigidity actually do a little bit better post-surgery, even in their best period than pre-surgery. So things like posture might improve a little bit just because you have something that's working 24/7 to kind of fight against some of those symptoms of Parkinson's. When we look at non-motor symptoms, so I heard hallucinations mentioned, but these are things like cognitive issues, hallucinations, mood symptoms, fatigue, blood pressure, bladder issues. All these things, they don't reliably respond with DBS. I do have some patients who will report some symptoms here and there that get better. You might have a friend who got DBS who felt like their thinking got a lot clearer after DBS, but those aren't reasons to do the surgery because they don't reliably improve. If you have side effects driven by medication and you can cut down on medication, that is one way it could improve. So if you're on a medication like, let's say, amantadine for the dyskinesias, which we know can cause a lot of cognitive side effects, possibly coming off amantadine might result in some improvement with the cognition, but it's not the stimulation that's directly affecting that. DBS also does not affect disease progression. So that's another thing that I think a lot of people will say is I want to do DBS to slow down my Parkinson's. It's another tool for treatment, just like the medication. It really isn't altering progression of things.
That's important to distinctly say, Dr. Tarakad. So thank you for making it very obvious that deep brain stimulation does not change the progression of Parkinson's. Who is a good candidate for DBS? If you could describe an ideal candidate for this surgery, how might you describe that patient?
That's another one. I feel that there's a lot of ideal candidates. I think your goals just need to line up with what DBS can help with.
Mhm.
Knowing what it can help with, if those are things that you feel it's worth it to do the surgery for, then I would say you're potentially a good candidate. It might be easier to say what is maybe not a good candidate or things that people might think are important that aren't really important. So things that are maybe not the best candidate for DBS. A big one would be if you haven't been on medication. I'm always surprised when we get some referrals over to our clinic for DBS. It's someone who never took medication, didn't want to start medication. They just want to get the surgery to make their symptoms better. And like I'd say, at least at our center and probably most places, they're going to want you to have at least tried medication before you're going to consider something like the surgery. Um, Separate from that, if you have cognitive issues, that's probably the biggest one that we run into. And it's normal for people with Parkinson's to have mild cognitive issues. So when we think of the ADD type of symptoms, a little bit of forgetfulness, things like that we expect to see, especially when we're getting into people who had Parkinson's 10, 15 years, you are going to see a little bit of a change there. So I wouldn't say, oh, I have some memory problem, so I'm not going to be a candidate for surgery. But if it's beyond a certain threshold, that does increase the risks of cognitive decline with the surgery. So at least at our center, a very big part of our evaluation process is doing something called neuropsychological testing, which is in-depth thinking and memory testing, which really helps us see who has mild changes that we expect with Parkinson's, who has maybe a little bit more heading more towards something like dementia, who probably wouldn't be a very good candidate for the surgery. Um, Things that I think people might think don't make them a candidate, but actually don't really matter so much. So one is age. So some people will have this number in their head that, oh, you can't do surgery after 70 or you can't do surgery after 80. There's really not an age cutoff for DBS. I will say, as people get older, the risks of other medical issues or cognitive changes do go up. So there's a lot fewer 85-year-olds who I see who are good candidates for surgery than 50-year-olds. But you can have a very young 85 and a very old 60. So the age itself isn't really a determining factor for your candidacy.
Mm. Thanks for clarifying that, Dr. Tarakad. We did get a couple of questions about how how old or can an elderly person consider DBS? So thanks for answering that. I want to give you one more question and be respectful of your time and our time here. What can be done for someone who had DBS and they feel that the effectiveness of DBS is declining?
So, I mean, changes happen over time. With, like I said, it doesn't affect the progression of Parkinson's. So, if your Parkinson's symptoms change, you might notice that some of your symptoms just become more prominent over time. But there is also something called habituation, which is your brain kind of adjusting to the DBS. So, it is in some cases a little bit less effective over time. In those situations, always worth talking about it with your doctor, seeing if you can kind of I found it useful in some cases to almost start from scratch. So treat it like when you first got the stimulator, just test everything again and see is there a new spot or a new location, fresh set of eyes, looking at it to see is there something that can maybe work a little bit better for you. Depending on the device you had, I talked about hardware update. So if you do have one of the older devices, changing to one of the newer ones might give you some more programming options. It's really been a surprise when we shifted from the old Medtronic batteries to the newer ones where we dropped that pulse width that I mentioned earlier below 60. So many people who were tapped on how high we could go on the stimulation, we were able to push it a lot higher, get a lot more benefit just by dropping that pulse width a little bit. So there definitely need things to try, but I would say talk about it with your doctor. Maybe consider restarting with the programming. Always try reprogramming first. If that doesn't work, then you can always talk about the mild surgery would be doing something like a battery change. If it's felt that the wires are just not in a good spot or not having the effect that they should, the next step would be working with a neurosurgeon to take a look at the placement of the wire. If they feel like it's off or they could improve it, there might be a discussion about doing a revision surgery, meaning replacing the electrode.
Perfect. Oh, great. Thank you so much, Dr. Tarakad, for answering our questions. And thanks to all of you for joining us today for our presentation on the innovations of DBS. Dr. Tarakad, always grateful to work with you. And I want to give an opportunity to thank our sponsor, Boston Scientific, for supporting the mission of the Parkinson's Foundation and for making this program possible. So thank you, Boston Scientific, for supporting us. If we weren't able to get to your question, please don't hesitate to reach out to the Parkinson's Foundation's helpline. That number is there on the screen. You can also browse our website at parkinson.org or email our Parkinson specialist at helpline@parkinson.org. And before you go, if you would, there will be, when we end the webinar, a screen will pop up and let us know what you thought of today's Wellness Wednesday webinar. Your feedback does get viewed by my eyes and my team's eyes, and we take your insights and your words truly to heart in how we deliver our programs in the future. So thank you so much for offering some time to give us your feedback. Again, if you had any questions that went unanswered, please don't hesitate to reach out to the Parkinson's Foundation's helpline. Dr. Tarkad, many thanks to you. Have a happy birthday. Until soon, everyone. Be well.